or we should wait? Good morning and welcome to our CPT class. Today I'm going to present about chronic inflammatory demyelinating polyneuropathy. I firstly want to go through very quickly on the case. A patient who presented with GP 1.5 years ago. So she was an 18 years old female. She was a native from Mustang district. She presented with a progressive lower limb numbness and weakness for a year. She was referred from Mustang district hospital to Manipal teaching hospital, where she stayed for around 6 months. 6 months ago then, and she stayed there for around 2 months. So there she presented with a lower limb weakness, some abnormal behavior, and she was stool and urinary incontinent. So when she reached to the ER, she needed intubation, and she had to stay in ICU for a month. So while staying in Manipal, she had they actually attempted for decannulation of tracheostomy tube 3 times. It didn't happen because she would not sustain even with the oxygen, and the saturation dropped down to 45 or 50. And there she was diagnosed with chronic inflammatory demyelinating polyneuropathy. On investigation, she had like lists of investigations, so I've jotted down just 2 of it here. So they did the anti-nuclear antigen positive in Manipal. They also did an MRI of head and whole spine, which showed lacunar infarct in right lentiform nucleus. So she also had an infarction. She had a patchy infarction on right temporal lobe, right occipital, eccentric periventricular white matter. And the MRI of spine showed some syringomyelia in D9 to D12. We are very unsure about whether they did a lumbar puncture or not there. So after everything happened and she was diagnosed with it, she went back home, and then she developed this pressure sore. So that was the main reason why she came to our hospital. So the management of the pressure sores. I think we had a holistic approach. We had involved our multidisciplinary team at that time, and I think Dr. Suraj also had a look on her. I think she came to plastic surgeon, and then she was referred to palliative to have a look, and then she later was primarily taken over by the palliative department. On examination, she was bed-bound completely. She was very cachectic. She had tracheostomy tube. She has NG tube for feeding. She was on Foley's catheter. She had large grade 3 to 4 pressure sores over the sacrum and bilateral ischia. So on motor examination, the right and left lower limb, she didn't have anything. There was no sensation, plus the power there was nothing. She was like flaccid. The right upper limb, she had a power of 3/5, so quite significant. At least she can go against the gravity. But the left upper limb, she had a severe contracture, and our occupational therapist has to really work on getting that contracture, working on that contracture. So the reflexes were decreased on bilateral lower limb. She had no sensation at all on the lower limb. So that was how she presented to us, and so it's a quick overview on her. So let's talk about the CIDP itself. It is an inflammatory demyelination disease condition. It is acquired, it is immune mediated neuropathy, so it affects mainly the peripheral nerves and the nerve roots. So when talking about this more characteristic, it has a relapsing and remitting course, or it can be progressive. So if we talk about our patient, it was more progressive and it was more deteriorating. It is glucocorticoid responsive, and on electrodiagnostic or pathological features, in electrodiagnostic test, it shows there's some pathological features of demyelination. Talking about the epidemiology, so the prevalence ranges from 0.7 to 10.3 per 100,000 people. I think it's quite significant. and it's more predominant in male with a ratio 1.5 to 4. It primarily affects the adults, and with the advancing age, its occurrence increases. I couldn't find any median age of onset on any literature, and there was no any specific predisposing risk factors. On talking about the pathogenesis, that's our axonal. We can see that there's a segmental demyelination and remyelination of the peripheral nerves, and we called it the onion ball formation. So there was first demyelination, and there was some remyelination, but the remyelinated axons were not as better compared to the first depleted or demyelinated axons. Also, we found autoantibodies in the paranodal proteins in 10% of the patients. So going to the clinical features, we had a classic form and a variance, 5 variants. So classic form is 50 to 60%. So most of the patient who comes to us would be presenting with a classic form. So they would have a symmetric motor predominant proximal and distal muscle weakness. The classic form onset is a very gradual, progressive over several months, and I think like we thought like it was what happened to our patient. She progressed gradually over months, and she had a symmetric weakness, and it was motor predominant. About the variants, you can see it consists of only 5 to 10% of the features. First is asymmetric sensory motor. Some patients, they have autonomic symptoms, and there is a neuropathic pain. They also have a cranial nerve involvement. Some patient with a focal CIDP with symptoms restricted to only one limb and nerve. So that is a asymmetric sensory motor presentation. In case of sensory predominant, it is mostly sensory and balance. They'll have pain, paresthesia, dysphasias in case of sensory predominant. In distal and sensory predominant is usually more slowly progressive compared to our classic form, and spare the proximal limbs, trunk and face. So additional features in that would be more ataxia. They have neuropathic pain, and reflex are typically absent in that. In case of proximal polyradiculopathy, it is more symmetric. Sensory ataxia is very marked in this variant, and it is very indicative of large fiber sensory dysfunction. If there is large fiber sensory dysfunction, there's more proximal polyradiculopathy variant. In case of pure motor, we have weakness which is relatively symmetrical and may involve the whole body and also the motor cranial nerves. So basically we can mainly remember or try to know more the classic form. So it's more symmetric, motor predominant, and proximal and distal muscle weakness. So that's what I have just told. So presentation can be more in proximal and distal muscle weakness. The first will be they'll have difficulty in climbing or descending stairs, and even from standing up from sitting position, they'll have frequent falls, tripping, difficult to open doors because you have that weakness on your distal muscles. So it tends to be worse distally. So you have started with proximal. I'm talking about the classic form though. So it starts with the proximal and then goes more distally, and it gets worse. So I think that's all what I have already talked about. And also quickly the presentation, the same thing. Yeah, so interesting is the cranial nerve and bulbar involvement. Some patient might not have any bulbar involvement, so bulbar is more like speech and swallowing. But our case, for our patient, it was more speech and swallowing as well, because she was on NG-tube for feeding. So that compromises 10 to 20% of patient. So if you, and painful dysphagia, there's even cauda equina syndrome can occur in those patients. In severe cases, we have autonomic involvement, bladder and bowel incontinent, which was also seen in our patient. So let's talk about the clinical course. It is gradually progressive symptoms over the course, most of the cases, but definitely we talked about relapsing and remitting course as well, and it has shown that it's more in pediatric age group. Rapidly progressive symptoms, it can resemble acute inflammatory demyelinating polyneuropathy, which is also termed as acute onset CIDP. Few of the differential diagnoses would be AIDP itself, but it does not progress beyond 8 weeks, and its prominent sensory signs are seen. There's impaired vibration and prick sensation, which gradually, if it's not treated in 8 weeks, or it's not goes after 8 weeks, then it turns towards CIDP. So other chronic demyelinating neuropathies like multifocal motor neuropathy, IgM associated demyelinating neuropathies, and we also have a genetic mimics of CIDP, Charcot-Marie Tooth disease. So it's like a genetic version of CIDP. So on diagnosis, I think it's mainly clinical. So it's very clinical diagnosis. So whenever a patient comes with a progressive or relapsing remitting polyneuropathy, it has to be in your mind that is it CIDP or AIDP. It can involve both motor and sensory axons, and weakness is very predominant. It has to be symmetrical. It can affect simultaneously both proximal and distal muscles. And the interesting is that there is no reflex. Areflexia is very important. Right? And also for initial suspicion, they say that they can do peripheral nerve diagnostic, like nerve conduction test गर्छौं त्यस्तै त्यसमा चाहिँ it shows the evidence of demyelination. So let's go about the diagnosis on criteria about clinical progression over last 2 months. There's a weakness of more than sensory symptoms, more weakness, symmetric involvement of arms and legs. So it kind of a weakness on your upper limbs and lower limbs. Proximal and distal muscles are both involved. There's a widespread reduction of and loss of tendon reflex. So it's very important to get your reflex if they come with a weakness. Increased cerebrospinal fluid protein without pleocytosis. So nerve conduction evidence shows there is a demyelinating neuropathy or conduction block or conduction slowing. Nerve biopsy also shows the same. If there is a gait ataxia, if you can catch the patient a bit early with the weakness, if there is a gait ataxia, then it's mostly due to the large fiber sensory loss. Let's talk about the management. For the management, the goals will be early treatment to stop the immune attack, because it's immune mediated. Immune attack against the myelin sheath of peripheral nerves, so that the secondary axonal degeneration is minimized. And also we can improve the symptoms and function and prevent the long-term disability. Initial therapy, we have intravenous immunoglobulin, plasma exchange, or glucocorticoids. IV immunoglobulin is easier to administer than plasma exchange for sure. Initial dose would be 2 grams per kg infused over 2 to 5 days. So many patients will require a treatment trial repeat after the 5 days as well. Plasma exchange would be 4 to 6 exchange over 8 to 10 days. So it depends upon the clinical response, how the patient symptoms response to the plasma exchange. Glucocorticoids I think there's more about pulse steroids. So we can start dexamethasone, prednisolone. So dexamethasone, it has shown like 40 milligram for 4 consecutive days, once a month. Or we can go a very high dose of prednisolone, which is 600 mg once a week. I think we didn't try, and we haven't tried to our new case. We have recently got a new case from rehab as well, but he's on steroid, and it was shown a very significant improvement with 1 dose, but it was not 600 mg once a week around. And then we can taper once the improvement occurs. These are the assessment of response to the treatment. So there's a disability scales. After the treatment started, we can go for how well it has shown its impact. Prognosis, there's limited data on long-term prognosis. So more than 85% relapse was very common even with the IV immunoglobulin, and also it's a very expensive treatment here. So prognosis wise, you can see in more than 1 year of treatment, it is stable and active disease. Patient is stable and they can carry over, but still the disease is active in 44%. You can see there's a remission in 24% in less than 5 years of treatment. There's unstable active disease in 18%, and 11% is cured in more than 5 years of treatment. But most of them is always fatal. So 60% of the patients, which I mentioned earlier, they are able to ambulate and work. 25% they become confined to wheelchair and become bedridden, and 10% die from their disease. I think in that 10% is not from only the disease, but it's also from, because she's bedridden, she has chance of infection, she's on NG tube, and there's large bed sore. So the other factors definitely play a role on the death. So in our case, what I talked about earlier, she had a severe disease and she had a poor prognosis. We didn't know what treatment she got when she was diagnosed CIDP at Manipal. And another sad thing was we were not able to wean off tracheostomy. We tried here, and mainly our goals of care was wound care, nutrition, caregiver training for wound, tracheostomy, NG-tube feeding, and urinary catheter. And she expired after 2 months of discharge from our hospital. Just to summarize, CIDP is an acquired immune-mediated neuropathy, male predominance. It has a symmetric motor predominant peripheral neuropathy that causes both proximal and distal weakness, sensory impairment, and areflexia. It is a relapsing and remitting progressive. It can have relapsing, remitting, or progressive course. It is definitely glucocorticoid responsive, and electrodiagnostic test, you can see features of demyelination. And that wraps up my presentation. Thank you very much, and these are my references.